Good afternoon, everyone. This is the STI Clinical Update webinar on Syndromic Management of Sexually Transmitted Infections, Part 2. My name is Rosalind Platzker. I am a clinical faculty member of the California Prevention Training Center and also a public health medical officer for the California Department of Public Health. I will be emceeing today's webinar and also going over a few introductory slides. So first, a little bit about the California Prevention Training Center. We are a multidisciplinary training center and capacity assistance center. We're sponsored by the CDC, and we're a member of the National Network of STD Clinical Prevention Training Centers, or NNPTC. We provide virtual and in-person training events, technical assistance, clinical tools, and STI clinical consultation services focusing on complex STI issues in patient care. To learn more, you can visit our website at californiaptc.com, and you can also look at the NNPTC website, which is nnptc.org. We also run the STD Clinical Consultation Network. The Clinical Consultation Network for our region fields questions for complex sexually transmitted infections. You can submit questions online at stdccn.org, and you will hear back from a subject matter expert within 1 to 5 business days via either phone or email, depending on your preference. These are our financial disclosures, and these are our CME disclosures. For today's event, we offer 1.25 CMEs. For CMEs, you have to be registered for the webinar on an NNPTC website. The registration is now closed, so you would have had to register for this beforehand. You do have to participate in the webinar in full, and you have to watch it live. You will complete a post-course evaluation, which will be sent to you, and you need to complete it by December 14th. If you registered for the webinar, you should receive a notification within 24 hours following today's webinar, and that will come from training@nnptc.org, and that has the link to complete the post-course survey evaluation. The email notification is sent to the email address you used to register for this webinar, and to ensure that the email notification is received, please either add training@nnptc.org to your safer trusted senders list, or you can check your spam or junk folders if you don't see that notification in your inbox within the next 1 to 2 days. This is a CME event via the University of Nevada, Reno School of Medicine. If you meet CME requirements, then you will receive an email notification from CAPTC within 4 to 6 weeks from the post-course survey evaluation deadline. So to summarize, you will receive a link within 24 hours that you need to complete by December 14th. And then in 4 to 6 weeks, you will receive your CME from CAPTC. The email notification for that is again sent to the email address that you used to register for this webinar. And to ensure that you receive the email notification, please add captc@ucsf.edu to your safe and trusted senders as well. And keep an eye on your spam and junk folders. Okay, a couple housekeeping things about the Zoom today. For the Q&A, the question and answers will be turned on, and you can access that during the webinar to submit any questions at any point during the webinar up to 2 minutes before the webinar ends. To use that, you use the Q&A box and you click on the icon, which is shown here, and that's from your Zoom tools to open the Q&A chat, and then you type your question and click send. You can click anonymous if you want to send your question anonymously, and questions from attendees will be answered either directly via me, or if there's a presenter who's not currently speaking who can answer in the chat window, that's also a possibility, or it can be saved until the end for our Q&A session. And questions can also be submitted during that Q&A session. During the webinar, the microphone, video, and chat will be turned off for attendees. If you have any questions related to anything that I've covered thus far, you can email our clinical program manager, Elizabeth Olson. Her email address is below, elizabeth.olson@ucsf.edu. And with that, it is my great pleasure to introduce our presenters, Drs. Kathleen Jacobson as well as Kelly Johnson. Dr. Kathleen Jacobson is the chief of the STD control branch and has been closely involved in the COVID-19 response as the chair of the California COVID-19 testing task force. Just prior to joining the California Department of Public Health, Dr. Jacobson was the senior HIV and TB care and treatment advisor to the United States Center for Disease Control and Prevention, CDC, for the country of Uganda. Previously, Dr. Jacobson was an associate professor of clinical family medicine at the University of Southern California Keck School of Medicine for 20 years, where she directed 3 medical school courses spanning all 4 years of the medical school curriculum, was a principal investigator on a number of multi-site studies on PrEP and HIV testing and rapid treatment, and the medical director of the Los Angeles Regional AIDS Education and Training Center. Dr. Jacobson has more than 28 years of clinical experience and has trained a few thousand providers in clinical care. Kelly Johnson, Dr. Kelly Johnson is the medical director of the California Prevention Training Center, a public health medical officer in the STD control branch at the California Department of Public Health, and an assistant professor of medicine in the Division of Infectious Disease at the University of California, San Francisco, or UCSF. She is board certified in both internal medicine and infectious diseases and works on the inpatient infectious diseases service at UCSF. Her research interests include the intersection between HIV and bacterial STIs, as well as real-world implementation of HIV PrEP. All right, and with that, I'm going to stop sharing my screen and hand things over to our presenters. Thank you very much.
Great, thank you so much, Dr. Plotzker, for that introduction. Dr. Jacobson, would you mind pulling up the slides and we can go ahead and get started?
Yes, I'm working on that right now. If I successfully do that. No, does not appear to be pulling them up. Give me one more moment. Sorry, everyone. I am not sure what's going on here, but let me try again. Here we go. Okay. For some reason, it wasn't showing my slides initially. Can everybody see that okay?
You've pulled them up, but they're still kind of like in the PowerPoint mode. Can you change it to being a presentation?
Okay.
Perfect.
Great, that looks great. Okay, welcome again, everybody, to our talk today on syndromic management of sexually transmitted infections, or STIs. This is part 2 of a 2-part talk. Next slide, please. We will be going over several learning objectives today. I'm just going to run through them so you have a list of the things we're going to cover. So first, we're hoping to help you identify presentations and a differential diagnosis for STI ulcerative disease. Second, we're hoping to help you understand that certain sexually transmitted infections can actually disseminate, so go outside of the genital tract, and that can sometimes result in disease, even very severe disease. Third, we want to help you recognize the clinical manifestations of some of those disseminated STIs. And that might include things like secondary syphilis, disseminated gonococcal infections, and mpox, or what was formerly known as monkeypox. Fourth and finally, we'll be covering how to diagnose and manage, in brief, certain disseminated STIs. Next slide. So we'll start with a case. Let's pretend it's July of 2022, and you have a 25-year-old man who has sex with man who has well-controlled HIV presenting to your clinic with painless genital ulcers. They've been there about 2 or 3 days. He denies any genitourinary symptoms, so he doesn't have any pain when he pees and he doesn't have any penile discharge. Socially, he is sexually active with men only. He has condomless oral and anal, receptive and insertive sex. And a genital exam reveals the following. Next slide. So here you can see these sort of punched out, rather large ulcers right where the glans penis meets the shaft of the penis. And they even have a little bit of a purulent looking exudate. Next slide, please. And we're going to go ahead and turn it over to you and ask as the audience, what do you think is the diagnosis for this ulcerative penile lesion? And we're going to give you some choices. I think you have to click next a few times if you want to see them on the slide, but they also appear on the poll here. So do you think the diagnosis is genital herpes, primary syphilis, mpox? Is it chancroid? Is it lymphogranuloma venereum or LGV? Or is it granuloma inguinale? We'll give people a few moments to cast your votes. Great, okay. Thanks for the poll, and can you show us the results? Okay, wonderful. So we're a bit all over the map here, but about 70% of people selected primary syphilis, and that was followed by chancroid, genital herpes, and mpox. We will tell you the answer, but not just yet. First, I'm going to turn it over to Dr. Jacobson to go over some of the differential considerations for a person who presents like this.
Yeah, great. Thanks, Kelly. So first, just in separating out the differential diagnosis of an ulcerative sexually transmitted infection, there's a few things that I use to help me try to figure things out. One is the appearance of the ulcer and whether or not that ulcer is painful, and then whether or not there's lymphadenopathy, and whether that lymphadenopathy is unilateral or bilateral. And then if the disease happens to disseminate, what's the sort of characteristic approach to that dissemination? So we'll go through these diseases, talking about it and thinking about it from those perspectives. Okay, sorry. Okay, so starting with herpes, which I know you all know very well. Genital herpes, the vast majority of cases are due to HSV2, and the vast majority of the recurrent cases are due to HSV2. However, in young women and men who have sex with men, there's increasing HSV1 etiology. Transmission is via contact with lesions, the mucosal surface, genital secretions, or oral secretions. And for HSV2, it's typically genital contact with genital HSV2 infection. And for HSV1, it's typically genital contact with oral HSV1. But really important to remember that HSV1 and 2 can shed from normal appearing oral or genital mucosa or skin. And for HSV2, that's asymptomatic. Shedding occurs roughly 10% of the days. And for symptomatic HSV2, shedding occurs roughly 20% of the days. The incubation period on average is 4 days, but can range anywhere from 2 to 12 days after the initial exposure for that first infection. As far as diagnosis, the ideal approach to diagnosis is actually to diagnose it via the lesions that individuals have and use a viral type specific HSV1 and 2 via NAT or culture, with NAT being the preferred test. If an individual does not have a lesion, we recommend for high risk individuals only, you could do serologic type specific HSV1 and 2 via NAT, but we really encourage folks to just limit that to high risk individuals who maybe recently had a case and are curious if it was HSV2, but really avoid just doing screening with serologic type specific HSV1 and 2, because the diagnosis can be pretty overwhelming for an individual, and there's a lot of confusion about test results. Finally, if someone has a systemic herpes, the recommended test of choice is HSV by PCR. The ulcers for herpes, again, most of you know this pretty well. They tend to be multiple and they tend to be painful. Although it is possible for them to coalesce a bit and look more like they're singular and sometimes be painless, but the ulcers typically multiple, painful, and they progress through stages from erythema to a vesicle, a pustule, ulceration, excoriation. And an individual may have multiple stages of the lesions present at the time that they present for clinical evaluation, or they may be gone or not yet arrived. It's common for patients, particularly who are having recurrences, to know those recurrences are coming before they actually get the lesions. They'll start to have the pain and discomfort that they remember from their previous episode. Herpes does disseminate. It can cause a pneumonitis, a hepatitis, encephalitis, or viral meningitis. So just images of the classic progression, beginning with the erythema or redness and possible swelling. The thin-walled, typically vesicles, which sometimes become pustules. Then those can ulcerate, and you begin to see the early signs of healing with some crusting, scabbing. And then once fully healed, you often will see a hyperpigmentation of where the lesions previously were. And again, just a reminder, the ideal way to diagnose this is really when an individual has these thin-walled vesicles, to take an alcohol swab, swab those lesions, take a 16 or 18 gauge needle and take the surface off the lesion, and then take a Q-tip and rotate it into that actual base of that vesicle, and then send that for NAT testing. And here are some examples of lesions that have coalesced a little bit, and they look a little bit larger in size with fewer overall lesions. And you can see images of vesicles, pustules, and then some scabbing on the left here. And always remember that individuals can get herpes in the urethra, so looking in the urethral area, as well as rectally, individuals can have rectal herpes. So always remembering to look for those. All right, so that's herpes. Again, classic herpes, multiple painful ulcerations. Compare that to primary syphilis. Again, typically transmission occurs via direct contact, can be bloodborne, and maternal to child transmission occurs. Incubation is typically 3 to 4 weeks, but can range anywhere from 10 to 90 days. During the ulcerative phase, the ideal test to do is a dark field microscopy test. However, those instruments are rarely available. I'm only aware of, I think, 2 or 3 throughout all of California that exists. So getting a dark field microscopy is a very difficult test to do in a clinic. Otherwise, serology testing, doing a combination of a non-TREP test plus a TREP test. And the non-TREP tests, again, are the RPR and the VDRL. And the TREP tests, the most common ones you're going to see are the TPPA, the FTA-ABS, the EIA, and the CIA. And just a reminder of the traditional versus the reverse screening algorithm. With the traditional algorithm, the initial test is the RPR. If the RPR is positive, then follow that up with a TPPA or other TREP test. And if that test is positive, then that person either has present or past syphilis. If it's negative, then syphilis is unlikely. That differs from the reverse screening algorithm, where you begin with a TREP test, typically EIA or CIA. If that's positive, then you go on and do the RPR. And if the RPR is positive, then that individual likely has either recent or past syphilis or current or past syphilis. If, on the other hand, the RPR is negative, then you do one additional test, the TPPA, and if that comes back positive, then that individual either has present or past syphilis. And in all of the cases, once you identify that a person has present or past syphilis, you really want to go back to the history and determine whether that's a new or recent infection versus a late or unknown infection, or maybe it's a previous infection that was adequately treated. So looking at primary syphilis ulcers or chancres, again, these classically are single and painless. They're well demarcated with raised borders that are rubbery to palpation, and they tend to stand out and are pretty obvious, although patients, because they're painless, may not see them. However, really important to understand that really with this current epidemic of syphilis, we're seeing more and more individuals who actually will come in with multiple ulcerations, and sometimes those are painful. So it can really confuse you. It can look a lot like herpes. Lymphadenopathy associated with primary syphilis is typically regional. It's rubbery, bilateral, and typically painless as well. And as you know, syphilis can go on and disseminate, excuse me, causing a rash, neuroocular, otic, or cardiac involvement, as well as skeletal or mucosal involvement. And here's some examples of the multiple and sometimes painful ulcers associated with primary syphilis, and you can see how these could easily be confused for herpes. And so it's often important to empirically treat for both syphilis and herpes while you wait for the test results to come back. And primary syphilis ulcers can occur at the place of inoculation, and so that can be orally, that can be on the hands, or other locations. All right, so we talked about herpes, which tends to have multiple and painful ulcers most commonly. Syphilis, which tends to have single, well-demarcated and painless ulcers with sometimes some local rubbery lymphadenopathy. Now we're going to compare those to a few less common ulcerative STIs, starting with LGV, which is caused by Chlamydia trachomonas serovars L1, 2, and 3, which is transmitted via direct contact with infectious lesions, and much like herpes, can be transmitted when there are no lesions. The incubation period on average is 10 to 14 days, and diagnostic testing is via NAT, which can differentiate LGV versus non-LGV or culture. And now the ulcer of LGV tends to be less well demarcated. As you can see, it's much harder to really pick out where the ulcer is here. It tends to sometimes be more like a papule than an actual ulcer. The lymphadenopathy associated with LGV is tender, and it's either inguinal or femoral, and it's often fluctuant or suppurative, and sometimes described as a bubo formation, which is really just a tender lump. And for individuals who have LGV with oral ulcerations, they'll have associated cervical lymphadenopathy. LGV does disseminate, usually causes a proctitis, can be associated with tenesmus, so similar to herpes in that it can cause that proctitis, a proctocolitis, and an inflammatory bowel disease-like presentation with bloody and mucus stools. They can develop colorectal fistulas and fissures, and they can develop a more disseminated presentation with fevers and a reactive arthropathy. And you can imagine that this could be easily confused with rectal proctitis. And then Haemophilus ducreyi, which is more common in Africa and the Caribbean, is spread through sexual intercourse via microabrasions. The incubation period is typically 4 to 7 days, and diagnosis is through special culture media, which I can tell you is not widely available. Having attempted to do this testing, thinking we have everything in place, still not able to actually get those cultures sometimes. And you know, I always like to tell medical students when I train them that even though it's Haemophilus ducreyi, I always say it's Haemophilus to cry because it makes the patients cry. It's exquisitely painful because there's often multiple ulcers that are deeper, and so they cause a lot of pain. There can be lymphadenopathy that's inguinal, and it's typically tender, and it can be suppurative. Because it's so exquisitely painful, individuals often do not progress past the ulcerative phase because they're in so much pain, they tend to present for care. And one more to complete the discussion about ulcerative genital urinary diseases is granuloma inguinale donovanosis. And this is more common in India, South Africa, and South America. I think important to recognize South America, which means that it can sometimes come up certainly in California through our southern borders. I imagine through some of the southern borders of other countries as well. The pathogen is actually Klebsiella granulomatous. Sorry, can't get that word out today. The transmission is via microabrasions during sexual intercourse, and the incubation is between 8 and 80 days, and diagnosis is through DNA molecular tests or visualization of the dark staining Donovan bodies on either tissue or biopsy. And what's classic about granuloma inguinale is that it is a very slow growing ulcer, but it looks much worse than it feels for the patient. So it looks beefy red and highly vascular and often bleeds, but it's painless for the patient. So very different than Haemophilus ducreyi, because that one is very painful. This one is very painless, but looks like it's very painful. This one can cause what's called pseudobuboes, which is due to subcutaneous granulomas. And individuals may develop secondary bacterial infections, but what's really unfortunate about this is that it's very difficult to treat. You have to treat till the ulcers have resolved, but it's common that there'll be relapse with granuloma inguinale anywhere from 6 to 18 months later. And here's what also is unique about this is that it tends to not be associated with lymphadenopathy. And it does extend into the pelvis and can disseminate into the intra-abdominal organs or bones. It's also to possibly have granuloma inguinale in the oral region, but it's more of a local extension as opposed to a true dissemination. And so just to cover the treatment for all of these, most of this I think you know well, but for genital herpes, it's acyclovir 400 milligrams TID, famciclovir 250 milligrams TID, or valacyclovir 1 gram BID, typically for 7 to 10 days, but those can be continued if lesions are not healed. For primary syphilis, 2.4 million units IM for a single dose of benzathine penicillin G. And typically it's that single dose for primary syphilis, and you don't continue it if the lesions aren't healed. You just need that single dose. For LGV, which is chlamydia, trichomonas, cerevisiae L1 through L3, you treat it much like you do chlamydia, only for a longer period of time. So you use doxycycline 100 BID, but for 21 days. You can also use alternatively azithromycin 1 gram weekly for 3 weeks, or erythromycin 500 milligrams for 21 days. For chancroid, it's any one of these four: azithromycin 1 gram, ceftriaxone 200 milligrams IM, Cipro 500 milligrams BID times 3 days, or erythro 500 milligrams TID times 7 days. And then finally, for granuloma inguinale, which again is a Klebsiella organism, it's azithromycin 1 gram POQ weekly or 500 milligrams daily for at least 3 weeks, but until the lesions are completely healed. You can also use doxy, erythro, or Bactrim on these patients. So back to our patient. The provider suspects primary syphilis. However, they have no dark field microscopy available. They order syphilis serology, but the patient declines to have the blood draw, but does agree to an empiric dose of benzathine penicillin G, 2.4 million units IM. However, the genital lesions do not resolve. They become increasingly painful, and the patient returns to clinic. Patient now has new anal lesions and some symptoms of proctitis. So thinking back to the cases we've discussed that have proctitis, there's herpes, right? And they can have proctitis, and those individuals can also have bloody or mucousy discharge. It's often quite mucousy. They could also have the other disease that tends to have proctitis associated with it is also LGV, which can have that proctocolitis, an inflammatory bowel disease, resulting in bloody and mucousy discharge as well. The patient does, though, in addition, have a papular rash that's noted over his back and trunk. And as we mentioned, the provider was suspecting secondary syphilis because the patient had a repeat exposure, but also was considering HSV and could be considering as well LGV. Syphilis serology was collected and the patient was referred to dermatology. And with that, I'm going to turn it back to Dr. Jacobson.
Great, thank you. And you can show the next slide. So originally the provider was thinking primary syphilis, as were you in the audience actually. And so now he's coming back, he's not really getting better. He has some findings suggestive of secondary syphilis. So the provider's starting to think maybe this is the diagnosis. So let's stop and talk about secondary syphilis for a moment. I think the first important point to make is that the chancre that you saw with primary syphilis, it actually is self-limited, meaning it goes away in most patients on its own, even if the patient didn't get any treatment. But then 2 to 6 weeks later, the patient enters a new stage of infection, the next stage of infection, which is secondary syphilis. Secondary syphilis is the result of dissemination of the bacteria or spirochetes that cause syphilis throughout the bloodstream and throughout the body. And because of that, the manifestations of secondary syphilis are widespread and also variable. I'll draw your attention to that orange box on the right-hand side of this slide and just go through some of those sort of variable presentations of secondary syphilis. So most patients do have a rash, and classically that rash does involve the palms and the soles. A lot of patients also have a generalized lymphadenopathy or may have constitutional symptoms, kind of as if they had the flu. They may also have mucus patches, which are these white plaques in the mouth, which we'll look at in a moment. Or they might have condyloma lata, which are a specific type of lesion that we're also going to look at. Additionally, they could have patchy alopecia or hair loss, and like other stages of syphilis, they could present with symptoms of neurosyphilis as well. Next slide, please. So I want to just go through a bunch of images of secondary syphilis, really just to drive home this point that secondary syphilis can look like a lot of different things. So here's a classic rash of secondary syphilis. It is a maculopapular sort of diffuse rash here shown on a patient's torso. And you could see how this could easily be thought of as a bunch of other diagnoses. For example, a drug rash to vancomycin or amoxicillin might look quite similar to this. Next slide. Here you see the rash affecting the palms and the soles, but I wanted to draw your attention to 2 points about secondary syphilis here. First, looking at the image on the left-hand side of the slide, you can see that these lesions, they look a little bit atypical in some senses. They look sort of old, they look kind of like scars. Even with these lesions on the palms and soles, you might not think first of syphilis if it wasn't already on your mind. And the image on the right-hand side of this slide shows what these sort of macules of secondary syphilis can look like in people who have darker skin tones. It can be a little bit more subtle, and you might need to really look for them and think about this diagnosis in order to find them. Next slide. Here are those mucus patches that we were talking about, also with secondary syphilis. Mucus patches are white plaques that appear in different parts of the mouth or oropharynx. If you were to take something like a tongue depressor and try to scrape these lesions off, they would not come off. And that is something that differentiates something like a mucus patch from thrush or oropharyngeal candidiasis, because with thrush, you should be able classically to scrape it off if you were to try to do so with an instrument like a tongue depressor. These lesions of mucus patches of secondary syphilis, they are infectious as well. Next slide. Just going through some of these other disseminated manifestations of secondary syphilis, here you see this patchy alopecia, which is random spots of hair loss. And I think you can appreciate that this looks also pretty nonspecific. This could easily be confused with alopecia areata, regular alopecia, and not necessarily be classic for syphilis if you didn't already have it in mind that syphilis can cause something like this in the disseminated form. Next slide. And here we have those condyloma lata that I alluded to previously. Condyloma lata is a term for these raised, usually whitish gray papules that appear in warm or moist regions of the body. So we see them in the perineum, the perivulvar area, or the perirectal area. And these are also highly infectious. I think when you look at them, you might even think of anogenital warts a bit. So secondary syphilis is something that should be on your mind as well if you see something that you think is an anogenital wart. Classically, warts would be a little bit more irregular looking and a little bit more like a piece of cauliflower. But again, you want to keep both of those things in mind if you see a patient who has something like this. Next slide. Okay, now time to seek your opinion again. This is a true-false question. We've covered primary syphilis as well as secondary syphilis. Is it true or false that the treatment for primary and secondary syphilis is the same? I'll give you all a moment to vote. Okay, can we see the answers, please? And thank you for pulling up the poll. Okay, great. We have a split here. So 70% of people think it is true, but 30% of people think this is actually false. Appreciate all the votes. And let's go ahead and show the next slide. So the answer is true. And next slide. Go back one, please. Oh, there we go. Perfect. So the answer is actually true, even though it seems a little bit surprising. Like secondary syphilis looks a lot worse, right, than primary syphilis. It affects a lot more parts of the body. Why would it be treated the same? But in fact, it's actually treated exactly the same. So primary, secondary, and early latent syphilis, that being asymptomatic syphilis within the first 12 months after infection, those are all treated the same. The treatment is benzathine penicillin G. The dose is 2.4 million units, and you give it intramuscularly in a single dose. The point I want to make in red on this slide is that the trade name for this medication is called Bicillin LA. We've seen some folks using Bicillin CR instead, and that's actually a mistake. Bicillin CR is a mix of short and long-acting penicillins, and it's not actually the right treatment for syphilis. So just keep that in mind as well. I put it in small font towards the bottom left-hand side of this slide, just to show you that there are some alternatives to penicillin that you can use in non-pregnant patients who might be penicillin allergic. And those might include doxycycline or tetracycline, both for 2 weeks, or you could try ceftriaxone for 10 to 14 days, but that's given IV or intramuscularly. Hard to imagine that that would be easier to tolerate. But all that to say, these are really our less preferred or suboptimal treatments, and penicillin G is really what you should be thinking about for patients with primary, with secondary, or with early latent syphilis. It is a one-time dose of this medication. And you can go to the next slide. I'm going to turn it back over briefly to Dr. Jacobson to tell us what happened with this case.
Yeah, so the syphilis serologies, in fact, came back negative. And dermatology evaluation was completed. The HSV PCR was negative. The biopsy of the lesion was without treponemes, and the lesions were re-swabbed and sent for additional testing. Kelly, what else are you thinking about on this case?
Yeah, I think, at this point, the patient has been tested for a lot of the things that would have been common in the United States that we would have thought about. So syphilis comes to mind, herpes comes to mind, maybe LGV might come to mind, although the lesion's pretty atypical. But I think, as you can already see with this slide being pulled up, if you think back to when this case was happening, this case happened in July of 2022. And that was sort of the height of when the Mpox outbreak was at its so far peak in this country. So I think at this point, with all the diagnostics that have been done, you would be starting to think about Mpox. And I'm going to cover that next. And I'm going to classify it as a sexually transmissible viral infection. And I want to point out that it can disseminate. And we'll cover the clinical features and management briefly of Mpox next. Next slide. So as I mentioned, Mpox is a viral infection. Specifically, it's in the family of viruses called orthopox viruses, and it's actually related to smallpox, but generally, happily, much less severe. Mpox is endemic in some parts of the world, namely West and Central Africa, and the natural reservoir is actually unknown. It is thought that maybe African rodents or small non-human primates might harbor the virus, and maybe that's how people get infected. But over time, cases in non-endemic countries have also occurred sporadically. And historically, these sort of sporadic cases have been linked to things like international travel or to imported animals. For instance, interestingly, in 2003, there was actually another Mpox outbreak in the United States. About 40-something people were infected, and all of them actually had this exposure to pet prairie dogs. And it turned out the pet prairie dogs had been housed with some mammals that had been imported from Africa. So the prairie dogs got Mpox and then passed it on to their humans. In that 2003 outbreak, there were actually no cases of human-to-human transmission, which is very different from what we're seeing now, and there were also no deaths. So what's going on now? Since May of 2002, as I'm sure you've all heard, there has been an ongoing Mpox outbreak in non-endemic countries. As of a few days ago, in fact, there were over 80,000 cases in 103 countries that don't normally see Mpox cases. I'm just going to draw your attention briefly to this graph to sort of show you an epi curve of what's been going on with Mpox over time. On this graph, the dates are on the x-axis and the 7-day case averages are on the y-axis. And you can see that cases of Mpox kind of peaked, and this is global data, but they kind of peaked in July or August of 2022, and since then, happily, have started to come down. Though they still haven't been eradicated, we're still seeing cases. And especially if you work in a setting like an STI clinic setting, you may still be encountering cases in your practice. Next slide. And can you hit next one more time to show the graphic as well? Thank you. So I'm going to go over first some of the classic features of Mpox. I'll tell you what the classic features are. And then in a minute, I'm also going to tell you that we have seen some cases that have been a little bit atypical in the current outbreak. Okay, so back to classic. Now, classically, Mpox would have an incubation period averaging about 7 to 14 days, but it could be as long as 3 weeks or 21 days from exposure to infection or manifestations of infection. Again, classically, a patient would first develop a prodrome of kind of flu-like symptoms, what you see on the slide here. So fever, headache, fatigue, muscle aches, lymphadenopathy. And after that prodrome, about 1 to 3 days later, the patients would develop a rash. And the rash was sort of characteristic in that it progressed through a series of predictable stages. I'm going to show them more on the next slide, but I'll just verbally say them here. Basically, the rash would progress classically from a macule, flat lesion, to a papule, raised lesion, to a vesicle, fluid-filled lesion, to a pus-filled lesion, and then to a scab. Then it would fall off. Classically, there was also a sort of typical presentation of the rash whereby it would start in the head and neck area, tongue, mouth, then go to the face, then the arms and legs, then distally to the hands and the feet. What I did want to point out about the current infection is that things are a little bit different. So we have seen cases where patients don't have a prodrome, or they might get their rash before they get their prodrome. So that's one sort of atypical feature. And then another atypical feature is that we've also seen some cases where the patients present exclusively with genital or perianal lesions. And in some cases, those lesions don't disseminate anywhere else. And patients might actually present primarily with symptoms of proctitis. So just some things to keep in mind about what's different in the current outbreak compared to what I'm showing you here with classic mpox. Okay, next slide, please. So here's this rash progression in classic mpox, just to kind of give you some images of what this progression looks like. So the rash would start on the left-hand side with a macule, a flat lesion. Then it would progress to a papule, a raised lesion. You can imagine if you were to run your hand over those lesions, they'd be raised. You'd be able to feel them, palpate them. The lesion would then progress to a vesicle, which is sort of a fluid-filled lesion, and then to a pustule, kind of like a pimple, a pus-filled lesion, and then to a scab. Importantly, by the time you're seeing vesicles or pustules, these lesions typically develop a central umbilication, a little dot in the center. I think you can see it best on the image of a finger under the pustule section, where there's a little tiny dot in the middle of that finger. And I'll show you some more pictures of that in the subsequent slides. Overall, the rash is classically described as being well circumscribed, deep-seated, and having that umbilicated center. Next slide. Thanks. Here are the symptoms that are reported most commonly in the United States to the CDC in the current mpox outbreak. So you can see rash is by far the most common symptom. Almost all patients have a rash, followed by things like fever, malaise, and chills. Lower down on the list, you see proctitis. Again, that is a presentation that is atypical, but that we are seeing in the current outbreak. And then I'll say, just based on experience, it's not reflected on this slide, but patients have also presented not uncommonly with symptoms of pharyngitis and with oral lesions. I'll show you those as well in a moment. Next slide. Okay, so I also just wanted to point out briefly that mpox is an infection that can have severe manifestations. Most cases are mild or moderate, but some patients have been hospitalized, some have needed ICU level care, and it's also true that 17 deaths have occurred in this country from mpox. The potential for severe disease is increased among people who are immunocompromised, especially people with HIV who have a CD4 count of less than 200. And the boxes on this slide are just meant to show you some of those severe manifestations. I won't go through all of them, but just to point out a few. Some patients get really severe necrotizing lesions. They can get super infected. Patients have needed amputations and extensive debridements. Other patients have had encephalitis or central nervous system complications or spinal cord problems. Ocular complications or problems with the eye have also occurred related to mpox, and it actually can be something that would threaten a patient's sight. And then some of these oral lesions can cause significant problems with oral intake, such that patients may need to get hospitalized solely because of how dehydrated they might become. And I'll just leave the rest of these here for you to have for reference. Next slide. Okay, the rest of the time on mpox, I'm just going to show you some of the lesions so you know what they look like. These are some of the more typical genital lesions of mpox. And you can see these have that central umbilication. You can imagine they would be palpable. And some of them, like this lesion on the right-hand side of the slide, have started to develop that scab, which is kind of the final stage. Next slide. However, mpox genital lesions can also be kind of less typical or atypical. The image in the middle of this slide, for example, was our case patient, and this was based on a real patient that was shared with me by an STD controller. And this was a patient who actually the STD controller told me, quote unquote, I would have bet my retirement that this was syphilis. And I would have thought that too. And I know that you in the audience had also strongly suspected primary syphilis. But it turns out this patient had non-reactive syphilis serologies and even had a biopsy of this lesion with no treponemes identified. However, his Mpox PCR came back positive. So the diagnosis in that case was ultimately Mpox. So really important to think about it, especially if you see some of these atypical genital ulcerations. Next slide. Here are some of the skin lesions involving the palms, the soles, the face, classic lesions here with that central umbilication, and some of them do have some surrounding erythema. Next slide. However, again, some of the lesions might look less typical. For example, this patient, I might have thought this patient had something just as minor as acne or cystic acne if I didn't contextualize it with the patient's sexual history and with the fact that Mpox is occurring even now. Next slide. And here are some disseminated or really severe lesions. This is also Mpox. I might have missed this diagnosis if I hadn't thought about it. I might have thought this patient had, for example, really bad scabies, especially if he said he was really itchy, which he was. But I think if you look closely, you can see that some of these lesions are developing that central scab, those central dots that, again, would be more suggestive of something like Mpox. Next slide. This is an image from the CDC. This is just showing how severe some of these lesions can get. And again, some patients have required things like extensive debridement and even amputations to deal with some of these more severe skin manifestations. Next slide. Here's some of the oropharyngeal lesions of Mpox. I think the image on the left looks kind of most classic. I could imagine those lesions as having that central umbilication. But then the other images I think that you see here look more atypical, sort of like irregular white plaques. So again, just having Mpox in your differential. I would also put mucus patches on the differential if I saw a patient like this one in the middle with that lesion in the back of the throat. Next slide. And here's a really severe manifestation of anal lesions from Mpox. This patient did have very significant symptoms of proctitis as well. And this was a patient with an advanced immunocompromising condition, specifically advanced HIV. I just wanted to put it up there to show you just kind of how significant this illness can be in some of these immunocompromised patients. Next slide. Now, very briefly, I just wanted to cover some of the diagnosis and management very basics of Mpox. So the diagnosis is by PCR performed on a swab of a lesion. There is a treatment. It's an antiviral called TPOXX. It's only available through this expanded access investigational new drug protocol. So there are some hoops to jump through if you do end up needing it. So just be aware of that. And there is a way to prevent Mpox, which is through vaccination. The vaccine is called Jeniose, and it's given as 2 doses, 28 days apart. Next slide. Okay, so I've already revealed this diagnosis, but just to recap, this patient did end up having Mpox, so keep that on your differential as well for ulcerative genital disease, in addition to everything else that we talked about on this slide. Next slide. Okay, now we're going to move on to our second case. You now have a 40-year-old transgender female presenting with macular and pustular lesions on her hands and feet. She'd had 3 days of joint pains that started at her left ankle and foot, then her left knee, and now her right knee. She also reports condomless oral and anal sex with male partners. And let's see her physical exam. Here's her physical exam. You can see lesions, mostly macules on the feet, and then one raised lesion on her thumb. Next slide. Okay, so our last audience question, what diagnosis do you all suspect here? Is this Mpox? Again, is this LGV? Is it disseminated herpes? Is it disseminated gonorrhea? Is it secondary syphilis again? Is it granuloma inguinale? Or is it Coxsackie virus or hand, foot, and mouth disease? In the interest of time, you can go ahead and show the results. Very split here. Okay, so we have 35% of people, again, thinking mpox, which is very reasonable, I think, for that thumb lesion. Then another about 30% of people thinking of DGI or disseminated gonococcal infection, and about 20% thinking of secondary syphilis. So lots of things to discuss here, and I will turn it back over now to you, Dr. Jacobson, to take us home.
Yeah, and I think just to add, it's actually great that people have a mixed differential diagnosis, because what we really want is for you to be thinking of all of these all of the time and then try to delineate them out. So the case continues. The lesions are swabbed for mpox PCR. Given the provider's most recent history with the previous case of mpox, the patient's advised to cover those lesions, to isolate and return PRN. And ultimately, the mpox result comes back negative. However, the patient represents to clinic. He's now got worsening joint pains, new skin lesions, and full STI testing is done. And here's some of the lesions that you're seeing. You can see perhaps a pustule with a question of a central umbilication, some erythematous base, and more of a pustule here. And so the question is, what is going on with this patient? We thought mpox, and I think that was a reasonable suspicion given the lesions, the possibility of the central umbilication of those pustular lesions, but the testing came back negative for that. Could this be LGV? Recall LGV is more likely to have more of a proctocolitis, an inflammatory bowel presentation, which has the ability to disseminate and does have a reactive arthropathy. So LGV is within your differential, and it's reasonable to think about that. Could it be disseminated herpes? Remember, we went through the classic erythema, the vesicle or pustules associated with herpes that then can go on to ulcerate and scab over. So it's within reason that those could be herpetic lesions. Could it be disseminated gonorrhea infection, which can also have very similar lesions or skin rash associated with it? Secondary syphilis, maybe a little less likely here given the characteristic of those lesions. And then granuloma inguinale, recall granuloma inguinale is that red, beefy, slow growing ulceration that tends to be painless. If it disseminates, it tends to disseminate more locally into the pelvis and then into the intra-abdominal organs. So probably less likely granuloma inguinale here. And then Coxsackie, I tend to think of that on the tips of the fingers, the tips of the toes, and sometimes the tip of the tongue. So possibly, it's certainly not out of the question, but it doesn't seem to have the characteristic pattern of a rash associated with Coxsackie. And recall, just bringing back up these images that Kelly just showed you, reminding you of that central umbilication, but really the ability to go across the spectrum from macule, papule, vesicule, pustule, and scab, very much like herpes can. And so keeps all of those within your differential diagnosis. Secondary syphilis, again, probably less likely here. In my experience with secondary syphilis, one, I would just add that a lot of people can look right at secondary syphilis and not recognize it because it does really sort of hide. A lot of people think that these are scars on the feet or scars on the hand. And the rash can be so subtle that it's not recognized, or it's thought to be a drug eruption. But what about disseminated gonorrhea? We haven't really talked about that yet. So DGI can cause a bacteremia with fevers and chills Individuals can have skin lesions associated with that, and I'll go through those skin lesions on the next slide. Polyarthralgias is common, and they are typically asymmetric and migratory, moving from one joint to another, typically involving the wrist, elbows, knees, and ankles, and those can progress to a septic arthritis. Individuals can also get a tenosynovitis, which can occur on the dorsum of the wrist and hands, or they can develop a dactylitis, causing diffuse finger involvement. It can also present more seriously with meningitis, endocarditis, or osteomyelitis, and roughly 0.5 to 3% of gonorrhea infections will result in disseminated gonorrhea. And as you're probably aware, there are increases in gonorrhea cases across both California and the US. And so you're likely to see increases in disseminated gonorrhea cases at this time. The skin manifestations are most often seen with the bacteremic version of DGI, and they include a rash that is typically painless, non-pruritic, and will have small papules, pustules, or vesicular lesions. Individuals can have abscesses, cellulitis, petechiae, purpuric macules, a vasculitis, or even a necrotizing fasciitis. And here's examples of those lesions. I think you can see the vesicular lesions pretty well here. That's a fairly large petechial lesion, but meant to be a petechial lesion there. And also some pustules here. Septic arthritis historically occurs in less than 50% of DGI cases. Usually it's monoarticular or oligoarticular, and it rarely results in osteomyelitis, but it can. Testing for DGI, NAT testing or culture of the urogenital area, the pharyngeal and rectal area, and any mucosal sites, plus sending culture on blood, any of the skin lesions. If a joint is involved, doing a tap of that joint and sending synovial fluid or CSF fluid if the patient has meningitis. And we've got one last audience response question here for you, which is, what is the treatment of DGI? Is it ceftriaxone, 500 milligrams times 1 dose, benzathine penicillin 2.4 million units IM times 3 doses on a weekly cadence, doxycycline 100 milligrams BID, aqueous crystalline penicillin 18 to 24 million units daily times 10 to 14 days, or ceftriaxone 1 to 2 grams IV. And do you want to show us our responses? All right, good. So a mix of responses here with 55% of individuals choosing ceftriaxone 1 to 2 grams IV every 7 or daily for 7 days. 19% of individuals choosing ceftriaxone 500 milligrams IM times 1 dose, and some folks choosing penicillin and doxycycline. Next, whoops. We can go ahead and close that. So the treatment for the arthritis or the arthritis dermatitis syndrome of disseminated gonorrhea is ceftriaxone 1 gram, either IM or IV, every 24 hours for a total of at least 7 days. Alternatively, you can use cefotaxime or ceftazine 1 gram every 8 hours, but again, it should cover at least 7 days. It is possible to switch to an oral agent, ideally guided by antimicrobial susceptibility testing, and you should wait to make that switch until 24 to 48 hours after you see substantial clinical improvement in the patient's presentation. If you don't have that susceptibility testing, it's okay to use empiric oral treatment with Cefixime 800 milligrams POBID. However, we have been in the midst of a Cefixime shortage, so it's not always available. You can only use it if you have it available. One thing to be aware of is that California has had some demonstrated resistance to both doxy and ciprofloxacin for DGI, and both of those can commonly be medications that patients will be switched to empirically. So really important to understand that that resistance has happened. And so ideally empirically use Cefixime 800 milligrams POBID if you have to empirically switch someone. As far as meningitis and endocarditis, both of those use ceftriaxone 1 to 2 grams IV every 12 to 24 hours. Meningitis is treated for 10 to 14 days, whereas endocarditis is treated for at least 4 weeks and often up to 6 weeks. And be aware that endocarditis may require heart valve replacement, and we have had a few of our cases in California that have required that. As far as septic arthritis, that's typically treated with ceftriaxone 1 to 2 grams IV daily. So just notice the difference there. That's daily compared to meningitis and endocarditis, where it's every 12 to 24 hours. For septic arthritis, ideally those patients get a surgical washout, and they're typically given anywhere from 1 to 3 weeks of treatment following that surgical washout. Really important to do those joint aspirations to try to confirm that diagnosis of septic arthritis. And let's go back to our case. Our patient is admitted to the hospital for further management of their ongoing joint pains. They have no significant joint effusions on exam, but blood cultures do come back positive for gonorrhea. So patient is treated with 1 gram of IV ceftriaxone for 7 days for DGI arthritis dermatitis syndrome. Recall this patient had that migrating polyarthropathy that was occurring, and patient made a full recovery. So now to just take a moment and review our learning objectives. We did identify the various presentations of STI, ulcerative disease, and to just briefly review those and drive home those details. HSV, typically multiple ulcerations, typically those are painful, but they can sometimes coalesce and appear more like a single ulceration and are not absolutely always painful. Syphilis, recall, is typically a single ulcer that is well circumscribed with raised borders, and it's typically rubbery on palpation around those borders. But it is possible for syphilis to present with multiple ulcerative lesions that can look very much like HSV. For LGV, again, typically LGV has ulcerations that are associated predominantly with a tender inguinal lymphadenopathy, and they can get that bubo formation, versus Haemophilus ducreyi, also known as Haemophilus ducreyi, in my opinion, because it makes patients cry because it's exquisitely painful. They often have multiple lesions, and they can have painful lymphadenopathy, versus lymphogranuloma inguinale, where they typically have that singular ulceration. It's often very beefy red in appearance and looks like it should make the patient cry, but it is not painful at all. And they typically have no lymphadenopathy. And then I think Kelly did a great job of covering mpox, which can have a variety of different lesions that can ulcerate as part of their process, where they can go from a macule to a papule to a vesicle, a pustule, and ultimately ulcerate, but they have that classic central umbilication associated with it. From there, we went on and we discussed that certain STIs can disseminate outside the genital tract. sometimes resulting in severe disease. We talked about HSV, which can disseminate and can cause a pneumonitis, a hepatitis, and encephalitis. We talked about syphilis, which can cause the classic secondary syphilis rash we talked about. It can cause neuroocular and otic syphilis, and it can also involve the cardiovascular system. LGV, which is more likely to cause a proctitis or a proctocolitis that can cause a bloody mucousy stool associated with it. Individuals can develop fever and they can have a reactive arthritis. And then Mpox, which has the ability to disseminate, causing headache, myalgias, and fatigue, along with the very classical, but sometimes very aggressive, progressive rash presentation. And then DGI, which can present as an arthritis dermatitis presentation with rashes that can be pustular or vesicular. And then DGI also having the risk of endocarditis, meningitis, or septic arthritis. We walked through some of these various clinical presentations and then talked about how to recognize them, diagnose them, and then manage them. And that concludes our presentation for today. And Kelly and I are happy to take any questions that folks may have.
Thank you so much. I think that was an amazing presentation. We have about 2 minutes for Q&A. And I do want to bring up one question that came up, and I think I mentioned this in the chat. So I was saving one question that I thought was interesting, and I do have a closing question. So for those that saw the chat, that's the spoiler alert. The question from the group was, can LGV rectal lesions also be by direct contact as well as dissemination? So, so I'd be curious what your thoughts are, Dr. Jacobson, if the LGV lesions do harbor the chlamydia infection that can then be directly transmitted.
Yes, I think that it could definitely be directly transmitted.
Okay, excellent. And then my last question, we have 1 more minute left, is just about counseling patients. So I open this up to both of you, Dr. Jacobson and Dr. Johnson. If you have a patient in front of you who has an ulcer, there's unknown origin when they're in front of you, and it could be any number of these, and obviously that's very anxiety inducing. What do you say to them in terms of your own thinking on how you would work this up? And what do you say to them in terms of prognosis and maybe even just helping them through any anxiety they might be having in that moment? And I'm going to be sharing a slide while you answer.
Okay, I'll stop sharing then real quickly.
Yeah.
And
thank you. Yeah, so what do you tell your patients when they come to you with an ulcer and you just don't know the answer yet?
Yeah, I usually like to explain to the patients what I'm seeing and what my suspicions are. And, you know, often with sexually transmitted infections, we'll empirically treat while we wait for the results to come back. And I think that in and of itself can be reassuring to patients to know that that they're going to be empirically treated, and I'll tell them which particular infections I'm suspicious for and which ones I'm treating, and I'll give them my sort of list of highest suspicion to lowest suspicion, and therefore which ones I'm going to treat. And then, of course, I tell them that we want them to abstain from sexual activity until the lesions are clear or we've completed the treatment, depending on what disease we're particularly treating. Kelly, do you want to add anything to that?
Not really. I think that was a pretty comprehensive answer. I mean, I totally agree with talking the patient through, like, here's what I'm seeing based on your symptoms, here's what I'm suspecting, here's what I recommend testing for. And if you're offering empiric treatment, agree with explaining the treatments and potential side effects. In terms of trying to be reassuring, you know, if it's something like, if you're highly suspecting something like syphilis, that's very treatable with a one-time dose of penicillin. So you can be reassuring there. If it ends up being something like herpes that can recur, then sometimes I think that warrants a larger discussion, and I'd probably wait myself to have that discussion once I had the results back to confirm.
Thank you both. And your patients are very lucky. That sounds like a great approach to counseling. I want to just close with a few reminders. One is about CME requirements. Again, this is for people who have registered for the webinar prior to the deadline. So at this point, registration is closed. But if you did register for that webinar and you made it to this point, so you've watched it live and in full, congratulations and thank you for joining us. You should be receiving a post-course survey from training@nnptc.org. That should come to you within 24 hours. And please complete that by December 14th. Once that has been completed, then in 4 to 6 weeks, you will receive a different email that has your CME, and that will be coming from CAPTC. So with that, I hereby close our webinar, and I want to especially thank you, Dr. Johnson and Dr. Jacobson, for an excellent presentation as usual. And I hope everyone has a great rest of your afternoon. Thanks very much.
Yeah, thank you, Roz. Thanks, everyone.
Thank you all.